Hello, everyone. We are going to close this year's conference with a session focused on one of the most operationally complex and financially significant areas impacting rural healthcare organizations today: revenue cycle performance. Revenue cycle challenges rarely exist in isolation. In many organizations, performance gaps stem from breakdowns in communication, unclear ownership, inconsistent accountability, and misalignment between operational, clinical, financial, and external vendor teams. In this session, Amy Graham of Stroudwater Associates will be joined by Melissa McAvoy, CEO of Millinocket Regional Hospital, to discuss how leadership alignment and governance structures directly impact financial performance across both internal and outsourced revenue cycle models. The discussion will explore practical approaches to strengthening accountability, improving vendor oversight, aligning clinical and operational teams, and creating clearer ownership around financial outcomes. Participants will also hear real-world perspectives from rural hospital leadership on how organizations are addressing denial management, cash collections, coding accuracy, and operational coordination challenges. Attendees will leave with practical strategies for elevating revenue cycle performance from just a back office function to a broader organizational leadership priority tied directly to long-term financial sustainability. Amy and Melissa, let's take it away.
Hey, thanks, JD. I'm here with Melissa, as he shared it, and we just want to thank you for joining us. So today's conversation, it's going to be about 30 to 45 minutes that we're going to be chatting with each other about this engagement. Melissa and I feel like we're old friends now, and we had a change to the agenda today in that Ryan was supposed to join us. But due to an emergency, he's unable to. So we're going to cover the pieces that he was supposed to have as well, and then just want to chat about it. So if you in the audience have any questions for us, feel free to send it through the Q&A box. We'll be happy to answer those as we're having our discussion and share that along with you. So we really want it to be conversational in nature and go from that. So with that, let's just talk about it. Here are our faces. And Melissa, can you tell us a little bit about Millinocket? I know you're going to be the newly named CEO, and you start there on July 1st, we discussed, but can you tell us about your facility and some of the challenges that you've been facing lately?
Yeah, so we're a small critical access hospital. We have 25 beds. We live in a very rural part of Maine, so there's not a huge abundance of people to choose from to staff positions, not only clinical, but revenue cycle. About 8 years ago, we outsourced the majority of our revenue cycle to an outside vendor, and all of our billers went to work for them. Our coders still work here. And it has come with its challenges. Over the last couple of years, we've had a lot of changes. We upgraded to a new EMR. We lost our revenue cycle director that had been here for nearly 50 years. And we've had some turnover in our controller position. So there's just been a lot of moving pieces over the last few years that have created some challenges.
Mm-hmm. And so you got on this new EMR platform. When did you go live on that? When you went live?
In May, the middle of May 2024. So it was the middle of the fiscal year, the middle of the month. It was a nightmare.
And from that, so in looking at it, when we were thinking about this project and ways that we could help support your organization, that was one of the elements too, that you had a good 18 months to let that all settle. Was that something that you were expecting to have, like, hey, we're going to go to this new EMR and it should settle down like overnight? Or were you planning that it would take about 18 months to settle down?
We had heard some horror stories, so we were planning for it to take a little bit of time. We didn't even drop claims for the first 6 weeks. We were in Meditech, so we knew we were going to have a little bit of growing pain through the process. We did not anticipate the pains or the difficulties on the collection side and the billing side, because that is all outsourced. And so the clearinghouse didn't change. All of those things stayed the same. So we didn't expect it to take 18 months to turn around. And in fact, it hasn't completely turned around even now. So
Yeah, and not to give a horror story to everybody listening, but we talk to so many people, Ryan and I do, when they're going through these EHR conversions, and they're like, "Yeah, we'll be ready in 6 months," and it's like, wait, but that 18-month time frame is something that we really see. And you also bill like method two billing for your ER. So since you have that critical access hospital status, you have that alternative billing method. So is your billing company, were they familiar with that? Is that like a separate set of standards that you were having to go through to get your system set up for that billing piece of it?
not really because it's already set up. We built our Meditech system so that the charges get put in that then exports nightly to their clearinghouse, and they actually bill out of their own clearinghouse software. So it
Oh,
really
okay.
shouldn't have been such a huge challenge. All of those things were set up when we went to them, back in
Hmm.
2018. So the
Right.
majority of it should have really gone quite smoothly.
All right. But then you did encounter those hurdles. And so when we were talking about this project and having a revenue cycle assessment, I did want to take a minute and just point out, though, that this project was something that fell under the Small Rural Hospital Improvement Program, the grant funds that are administered, as part of the the Health Resource Services Administration, HRSA. And with the Maine Rural Health and Primary Care Program, they've contracted with Stroudwater to do it. And so we were able to do this project, do this revenue cycle assessment for your organization by, leveraging those funds and leveraging that grant opportunity. And so while your organization was facing some challenges getting the cash in the door from that EHR conversion, that was necessary. That was a program that you could leverage for that reimbursement, correct?
Right.
Yeah, and working through that. So, can when we talked to each other and we were talking about this SHIP program that's there and the project, were there some expectations you had in walking into it, the revenue cycle assessment and this ongoing project?
So we've worked with the SHIP grant for a number of years, and it's always a little bit different depending on what project we take on and what consultants we're working with. But I did expect to walk away with some action items and some things that we could do to help maybe move ourselves in the right direction.
Hmm.
And we did accomplish that. I honestly expected you to be more dismayed at the state of our revenue cycle than you were. But I was pleasantly surprised. But
Yeah.
yeah.
Well, and that was one of the things. It's we I that's one of the challenges that people in critical access hospitals see, and even in rural facilities, is that they see, it's like, because you don't have that network, you're only built, you're in a rural part of the country. And as I say to people that I work with, that I meet all the time, it's like you're 25 miles from the next nearest facility. And finding that revenue cycle person to find, that understands your woes. It's like what we saw at your organization was a lot like what we see at a lot of facilities, in managing it. But one of the things I would commend you on is that you really had your thumb on the pulse of your organization or of your vendor, your outside vendor, because I know that you had several conversations with them. They were listening to you, maybe, because you were standing on their desk demanding that they listen to you, but really had shared that with them and were holding them accountable. Can you share a little bit about how you hold them accountable for it and the performance that they have within within that vendor relationship?
So when we signed our most recent contract with them, we thought we had put some teeth into the contract as far as being able to hold them accountable. There was upside risk for us if things were going well in our performance, and downside risk for them if things were not going well with them. What we quickly discovered is the metrics that they were basing those performance incentives on were their own metrics, and it was a bit of a race to the bottom. So we weren't able to actually really leverage anything contractually. So it's really been a matter of me finding out who was responsive and who knew what they were doing and who could make things happen, and just really staying on top of them.
hmm When looking at it in this project, it was you had been having those discussions, having those conversations with it, identifying the priorities with them. But one of the things that we realized in talking to you is that uh, sometimes in your role working with them, you can start to think, shouldn't they be doing this? This is an assumed, here's where we put it into it, and that information is there. And so one of the things that we wanted to do is to help come in and help you set those priorities with that outside vendor, and really looking at ways that you can leverage that relationship. What we were seeing, working through the revenue cycle, comparing what you were doing against industry best practices, building that contract to have some teeth in it, they may have been baby teeth, but, still having that conversation to say, what can we do to help you out? How can we help support you in this? But then building those guardrails around it and the guidelines. You did have a recent turnover with your staff. You shared that your director of patient financial services had left. Tell us a little bit more about how you were approaching that transition.
So our director that had been here, like I mentioned, nearly 50 years, retired, and we did hire someone kind of to assume that same role. And what we quickly discovered was that she had morphed herself into a jack of all trades that really wasn't replaceable with a single person. Um, that person also decided to retire after just a few months of being here. So we kind of teased the role apart, and I took on some of the things. And we just kind of teased it apart and gave pieces to the people in our organization that were best suited to do them.
Mm-hmm. And so, oh, so in working through the revenue cycle assessment, part of the structure that we had is that we just looked at the revenue cycle map and that mapped it out to say, here are the different areas, starting at the very beginning of what are your KPIs? How do you do vendor setup, provider setup, working through those pieces of it. And I think we started talking at the end of last year, the beginning of this year, to show up, and you were like, "Yeah, sure, come to Maine in January," and we're like, "Yeah, well, know, most people are
Loved it.
looking to come in October, and we were like, we can come tomorrow, or come in like 2 weeks." When looking at it, but having that piece of it, we started at the beginning of your process, and you just um, walked us through that discussion of, here's how we do our charge master. Here are the activities involved in setting that up. Here is what we do for prior authorizations and insurance verification. These are the tools that you're leveraging. As we started pulling at your parts and pieces and really getting into the nitty gritty of your activities within the hospital, I know we're talking to each other, but can you share with the audience what that was like having us all there? And I know we brought we brought the main office of primary care with us to help walk through that day. Can you give the audience a little bit of a perspective as to what that was like?
Yeah, I think so. I I was nervous about that. Once again, I'm not super strong in revenue cycle. It's not my background. And we didn't really have anybody from revenue cycle or anybody that was familiar with all the pieces of revenue cycle here that day. So I was a little nervous that I wasn't going to know what I was talking about. But we kind of just went through it. And the more we talked, the more I realized we were really doing a lot of things very, very well.
Mm-hmm.
There's always things that can be improved. But I think as we found the wheels falling off after our EMR conversion, it did do some really positive things. We found we were looking for the whys, what's happening, how can we fix it, how can we change, what can we change? And in that process, we ended up creating a position for strictly for prior authorizations, which has almost completely eliminated our prior auth denials. We basically only have those for inpatient stays now, which there's not really any way for us to control. So a lot of the things that we found as we were trying to figure out why there wasn't cash coming through the door, we were able to put fixes in place that in areas that we didn't even know there were problems that we never would have found if things had just gone fine. So I kind of hadn't really thought of it that way, I guess, until you guys were here and we were talking about it. And I'm like, oh, we never would have done this, or we never, you know, would have done that. I think the other thing that really became clear is that we really need to do some education with our department directors and our staff about everybody's roles and responsibilities in the revenue cycle. Just because you're a nurse doesn't mean that you don't have a responsibility to the revenue cycle. Because I don't think that that's not in the culture here. Luckily, the new EMR has made it a lot easier for charge capture, which is helpful, but people still really need to take responsibility and make sure that those things are happening and being done well.
Yeah. In getting everybody engaged and having those discussions, it really creates that culture that having gone through that EMR conversion, you all were used to pointing out this is an area that's going sideways, it's not working right, and getting to the root cause of it and putting some of those proactive elements in place where you're proactively looking at a change culture. What do we need to do to change it, to get to that, operational improvement so that it does flow downstream? And when you were making those changes, did you have that engagement with your third party billing company, or did you feel like sometimes they just, as I describe it, they throw the hand grenade over the wall and dash away?
Yeah, that's pretty much. I think that was they were throwing the hand grenades as fast as I was launching them. But it kind of, I think where we got to was, okay, they're going to try everything they can to make this something that we're doing, something on our end. Every time we asked a question, they explained it away as something that was going wrong, kind of in the front end processes. So the more of those processes that we created, the less ability they had to say, no, this is actually you guys, which has actually made a huge difference. They also, after we did our EMR conversion in May of 2024, they outsourced most of their billing and receiving to India. And so they have a company in India, and that just when we were starting to climb out from the EMR conversion, that happened. And that's the part we had never really recovered from. Just recently, and I don't even know if we've talked since, they have pulled our entire account back to domestic. So we have all domestic resources, basically in part because of the things that we learned in this project and the things that we've been able to fix. They kind of knew we were serious and realized that it wasn't on our end, that they really needed to put some resources, capable resources.
Right. And research that they, no longer, I talk to so many companies and they're like, or so many hospitals out there and providers, and they're like, we outsourced to this because we didn't have the resources to do it internally. And it seems as if it's brought us more work to do. It's, this was supposed to make our life easier, not create the challenges. But I think you really hit the nail on the head that you've got to work on those front end activities, because there are certain elements that, like, your coding is internal. You're not going to want them to come and change your coding for you. What does that, those are the things that are structured, that are owned by the hospital, and being able to manage that piece of it. So how about for a second, we go and poll our audience and see what they say about their area of revenue cycle that they believe represents the greatest opportunity for their organization. These are some interesting results I'm seeing. They're still coming in. All right, let's go ahead and end the poll and share the results. And so it's what I was expected that the majority of it is in the denials management with 33%. But one of the other areas that first started coming in was in the area of cash posting. So it sort of died off, but cash posting people were really responding in the beginning. But then you've got 17% sending in that insurance AR follow up. Vendor oversight and accountability does have a 13% as well as KPI performance. And then that front end registration eligibility. So, Melissa, with that front end piece of it is the area that you do control within the organization. They report it up through you and have that. Can you share a little bit about what you put into place for that front end side, the controls, and maybe give some insights to our audience?
So, our front end staff, our hospital front end staff does really a fantastic job. That wasn't one of our bigger problems. The actual registration and eligibility on the hospital side, they do a good job. They have an excellent director who, does make sure new people are trained, make sure they're capable before they're let go on their own. Within the EMR, you're able to check insurance eligibility, which does catch a lot of registration errors. So when they're using that, it makes a huge difference because it's going to come back if you've got something, if something's wrong that the insurance company is going to come back with, it probably will be caught in that eligibility checker. So that really wasn't one of our bigger, that wasn't one of our bigger challenges. I think our biggest thing was more and I think it's kind of all tied together. The insurance, the cash posting, which we should have kept ourselves because right now our outside vendor does the billing and the cash posting, and it's kind of like the fox watching the hen house a little bit. And then the denials management and the follow-up. What we've put into place, because we couldn't necessarily take the cash posting back, is that we have a very low limit on the things that they can write off without them being reviewed by someone internally. And God bless her, the woman that stepped up and taken on most of the revenue cycle director role has, really taken that job by storm and is really, pushing back on them, saying, no, this needs follow-up. You guys need to go back to the insurance company. You need to submit the documentation. You don't get to just write it off. So that's helped our denials that were actually get written off significantly.
And so with that piece of it, you have some denial reports that you all are managing or monitoring as part of this project set up, don't you? And can you tell us a little bit about how that process works with your organization that your new person has assumed to that responsibility? Is she managing them like here's in summary, or does she look at a high level of it? How to share with us how she does that piece of it?
So I think she and I both do a lot of looking at initial denials just to see, what's going on and how we can fix it if there's something on our end. And we also try to look at accounts that are aging that haven't been followed up on because there's been a lot of that happening. But if we can catch them before they're timely, then she's able to kick them back and just make sure that they're getting fought all the way. So she looks at account by account and kicks it back and says, no, this should be paid. Figure out how to fix it. And that's made a tremendous difference. It turns out that even when they're getting paid based on what they're collecting, if it's easier to just write it off, they're happy to do that. If nobody's paying attention.
If nobody is paying attention to it and really, digging into that data, You would like to think that you could just hand it to them and they're going to do their job. And because they're paid on collections, you're not going to have to worry about it. But you do face those challenges still. And
And
that's
it's
one
not
of,
even
oh,
small claims.
right.
I mean, they'll do that on a $100,000 claim and not even bat an eye. Just, yeah, you know what? They want all this stuff. It's not really worth it.
Yeah. Whereas to you, it's like $100,000 claim. I mean, you
Right.
know, it's like when you're living for every dollar that comes in and trying to manage that piece of it, it's like, what can we do to hold them accountable and really hold their feet to the fire? Do you have weekly calls with them and those discussions,
We
you
do.
know? Hmm.
Yep, we have weekly calls set up with both. So on that call is the billing team, the posting team, the follow-up team, the early out team, and my team here. Um, so that's been kind of good just to get everybody in the same room if there's systematic problems. And then outside of that, we kind of just reach out to them every
Hmm.
time we find something. So they get lots and lots of emails from us.
And I think one of the things that you mentioned a minute ago that I really want to come back and stress to everyone listening is that you have put systems and things in place in your current organization to prevent them from pointing the finger at your organization for not doing your job. It's like you have to you're saying that you've put edits in place or you have a robust prior authorization piece or the documentation being captured in the medical record and relaying that information over to the organ, to them to say, we've cleaned up our house. You need to clean up your house now. And
Yeah. It's
making
things
sure.
like trying to write off an account for not having an auth when they just really didn't look at the account for the auth.
Mhm.
So there was a lot of that going on for in the beginning, which I feel like that's gotten significantly better. Um,
Mhm.
but there's also a really long time that when we kept saying there's a problem, there's a problem, there's a problem, they kept saying, "Oh no, everything's going really well. Just look how good we're doing." I'm like, but you're not.
And
Um,
to have your own set of data to come back and go, but here are the real numbers. This is
and
what
that's
this
exactly
means.
what it takes is me building, my own reports and sending them to someone here that knows more than I do to make sure I'm not off base, and then sending them off and saying, like, it's black and white. How can you
Hmm.
not see that there's an issue?
Right.
Um, and that's really what it's taken to affect change.
Hmm. And to have that piece of it. So, when thinking about this, oh, we have another polling question. So, our second polling question is how aligned do you feel your internal teams and external revenue cycle partners are today? All right, we'll share in the poll. Share the results. So it looks like the majority are mostly aligned or somewhat aligned. We do have a few, 16% that say they're not well aligned. And then we do have those in the audience who don't use external partners. But I think, really talking about that alignment and having everyone on the same page to have that discussion and really understand it. Um, can you, I do want to circle back too. We'll stop sharing on that one. I want to circle back on your discussion about setting those guidelines. How do you have the communications with your external vendor now on managing these expectations? We were talking about as part of our recommendations and walking through it, we were looking at the challenges you were facing on cash posting that they were the ones controlling the write-offs and then the write-offs impacted your denials or they were controlling those denial codes. How do you have that conversation now as a result of the assessment and the things that we were discussing back in January?
So the conversation really just became, you guys can't do write-offs anymore because because you're not doing it correctly. So we reduced the limit of what they were able to write off small dollar balances. but we really review everything before it's written off. And that conversation kind of started at higher management and sort of filtered down through. We also requested and pushed for an action plan, and they're on iteration number 5 of the action plan at this point, trying to, you know, set goals. And we asked for there to stop being this, again, race to the bottom. Their assessment of their performance has traditionally been, well, this is net revenue based on what we collected in the last 12 months. So as long as we beat that, we're doing well. Well, if you were terrible for the last 12 months, it doesn't mean you're doing well now because you meet or exceeded that by a little bit. So we've reset the bar and really kind of pulled in some industry standards for AR days and some of those KPIs, days not final billed, and set those expectations based on industry standards as opposed to what they decided that those benchmarks should be. So the benchmarks are there. There hasn't been a ton of progress on meeting them, but we're hoping that with the domestic team back on, that will start to bend the other way. Hasn't gotten worse, so I guess that's good.
Yeah, that you're not losing ground. It's just, taking that slow journey up the mountain
Well, and I
to
think
get to
it takes a long time to see those changes too, because you get a domestic team on and now they have to go through, they have to clean up the claims, they have to resubmit them or submit corrected claims. And by the time those go all the way through, processing, it does take a month or two before you're really going to see a whole lot of impact, I think.
Yeah, to see that coming around. So, I know we've spent a lot of time talking about your key indicators that you, Melissa, are very focused on that data, using that data to have the conversations, because anecdotally you knew that the cash wasn't coming in the door, but then you had that data to drive it. Can you tell us a little bit about some of the things that you look for in your role to hold that vendor accountable, some of the key metrics that you're looking at and focusing on?
So I think the number one thing for me is net revenue. Our net revenue percentage dropped, or their projection of what our net revenue percentage should be dropped significantly by at this point it's almost 6% over not quite 2 years. And it's not that our contracts have changed. It's not that we're doing a poorer job of, registration or prior authorizations or any of those things. It really was just a matter of what they were collecting and what they were writing off. And those revenue percentages just took a complete nosedive. So that's really been the one I've been hammering the most is, this isn't, it's not acceptable and it's not sustainable. So we have to, whatever you have to do to fix that is where you need to focus. And that has leveled out too. Finally, it stopped dropping, which is good. It hasn't really started to come back up yet, but I do expect it will between having the prior authorization person in place and really watching the write-offs. And you have to watch all of the write-offs, not just the stuff that they're submitting for a prior auth write-off. I spend a fair amount of time reviewing what's written off for a contractual adjustment because we find that sometimes it's buried in there. It wasn't really a contractual adjustment. It was actually just that, it was denied for needing medical records or needing a coding adjustment. And instead of kicking it back for that, they just lumped it in with the contractual and off they went, which is why our net revenue percentage has gone so awry.
Right. It's the staying on top of those payers. I mean, managing the payers and the denials or the contractual write-offs. It just gets buried in there, and you've got to stay after it. And and I feel the need to point out that, Melissa, you don't have a team of data analysts that are helping you pull this information. I mean, I think one of our recommendations was that you needed someone to help you pull the data because you were the one out there doing it. So, you know, I think about those who are listening going, but I don't have a team to pull my data. And it's like, yeah, Melissa, do you have a team pulling your data for you?
We don't, and the analyst that we get reports from at TrueBridge is unfortunately the data comes and I can with a very quick eyeball tell you it's not right. I think I sent you one of those reports a month or so ago, and you immediately fired back and said that's not. There's no way that's right.
Yeah.
So I think that we have to. We've discovered that we can't rely on reports from outside. We really have to do and pull our own reports. Part of the problem we have in that is the new EMR makes it very, very difficult. Reporting is not an easy task. Nothing exports to Meditech. I'm sorry, nothing exports to Excel. You have to export it to a text file and hope that you can convert it clean, which almost never happens. So it has been a real challenge trying to pull and get data to be able to analyze, but we found ways around it.
Yeah, to get it there. And I think that you all are able to get a report that you become comfortable with and use that report to really leverage the information and know that, you look at it like this doesn't look right. Or you can look at an aging report, and if there are things that are aging in Medicare greater than 30 days, you're like, what's going on here? Medicare should be paying in 15. What has been missed? Why is this aging out? And setting those guidelines and expectations there for them.
We also
So,
discovered there were things that were sitting and not even getting billed until they were even if we bill it, it's going to just immediately deny for timely because they were just sitting in an unbilled status. So
mhm,
they have a person that's supposed to be watching that now, and we're watching it here just to try to make sure that that doesn't happen. That's where it becomes a little difficult that things are in two systems. We can see what hasn't left our EMR to be billed, but we can't see what has left our EMR and been imported to their billing system, but hasn't gone out the door yet. So it makes it a little bit difficult to watch those things. So we've had to leverage someone on the outside vendor team to try to keep them on top of that as well.
yeah, yeah. And so, I just realized that if I looked at the next slide, we've been talking about revenue cycle management. And I know that when we come in and we have these discussions, this was one of the first charts we were sharing with you to help you really, you and everybody else that we work with as a Strywater client, is to understand, when we talk about revenue cycle, it's very multifaceted, and getting your different areas understanding what their roles are. You were talking about the department managers, that they need to understand it, that they play a role in it, your physicians and guidelines, just looking at it. And then, with the assessment that we were doing as well, talking about some early wins and action steps. We provided some recommendations. We had this executive scoring and, giving you a red, yellow, green as part of that assessment to say these are the areas, and just sharing with the group that, hers with that, showing that, key performance indicators were well aligned with industry best practices, that you're monitoring that activity, looking at it. But then looking for other areas that you didn't really have anything that misaligned that required, immediate attention to it. But the majority of your areas, you're operating in best practices, or, partially aligned with best practices, but some modifications may be needed. And I think that, in addition to working on this, giving you an action plan of here's what we're going to do in the first 30 days, next 60 to 90, and changing that information over. Was that helpful to you to have an action plan to get to the next steps and where you needed to go as far as the recommendations and getting your organization aligned with industry best practices?
It was, it's been a little bit difficult because things are changing so quickly. We're
Yeah.
finally getting some response from the outside vendor, um, that they're making some significant changes on our account. So a lot of the things that we were partially aligned on were things that if we could get them doing what they're contractually obligated to do, we wouldn't be misaligned. So we put on hold some of the things that we thought we would actually do relatively quickly.
Hmm.
The good thing is that because we had those plans and because we made the outside vendor aware of those plans, that's what spurred action to kind of really get them set the fire, to
Hmm.
get them to off the mark. So even though we didn't put all of those things in play yet, just the fact that they knew that we were about to, I think we had talked about having an outside vendor look over all of our closed claims, or all of the claims.
For
Go ahead.
short pays and things like that. Yeah.
Yes. And, I think we will still do that at some point. But that kind of having that audit and having that trail of the things that the idea of having that done and having somebody really dig into their work really kind of spurred some reaction and got us probably more, gave us more leverage than we've had in the year and a half that we've been fighting about this. So it was exceptionally helpful in that way.
Yeah. So I do know we're getting close to time and wanted to see if we had any questions that are coming through. I didn't know, JD, I think you're still there. Just to say that it's open for Q&A if anybody has any questions about the process with Melissa or myself and how it works, and just some tips for managing your outside vendor, because I know that Melissa, you've really engaged them and had those conversations and facilitated it. Didn't know if you had any follow-up questions for me since the experience.
I honestly, I haven't had a lot of, I think every time I've had a follow-up question for you, I've just reached out and
Yeah.
gotten answers, which you guys have been awesome. We do appreciate the partnership.
And it
Um,
and it's not like you're changing roles or anything, have a lot of changes in your job or anything.
nothing's going
Nothing's
on.
going on there at Millinocket. Just a casual day in a rural
Yeah.
hospital.
So
So,
so nothing has come in yet on the Q&A, Amy. I guess I would just ask, perhaps it's Melissa or maybe it's you, but what's the thing that just, if you can do only one thing, right? If you can give advice to a CEO or someone that's running revenue cycle, what is the one thing that you would just say you must do this?
For me, if it was when it comes, if you're going to contract with an outside vendor, there's actually two things that are kind of equal. One is to make sure that there's teeth in your contract and like really well laid out expectations. And the other thing is, not to get talked into giving them too much. I don't think that we ever should have given them both the billing and the cash posting. I think that was probably one of our biggest mistakes in this entire relationship. So I think that's, and when you talk to outside vendors, most of them want to do not only the billing and the cash posting, they want to do the coding, and I mean they want all of it. And I just would be really cautious about that.
Sure.
yeah.
Amy, anything that you would suggest there?
I would say is to recognize that activities that happen, even if you've outsourced it or you control the entire revenue cycle process, is that activities that happen in the beginning stages have a domino effect. That if you do not have a robust, very robust front end process in place for insurance verification and prior authorizations, that you have no hope of ever getting it collected. That if you don't know who to bill in the beginning, you have no chance of getting paid. Do yourself a service to really look at those pieces of the process. And I know Melissa shared it that they have a strong front end, and they were having conversations with their vendor, and their vendor was saying, you know, this is your fault. This is your fault, and do everything you can to have that continuous improvement on that front end and what that looks like. Um, so
So we did just get a couple that have come in. How do you set expectations with a vendor on day one so that you're not relitigating scope 6 months in?
I think that's a matter of how much you're giving them control over, number one. And I think that the other thing is to make sure that you really have you go into the conversation early with KPIs, benchmarks, and what you really want to see from them, as opposed to trying to fix a problem by just shifting the responsibility, which I think we signed our vendor on before I started in my role here. And I think there was a problem in the revenue cycle. So instead of looking to see what that problem was, it was, okay, let's just shift it to, and these people know what they're doing, so let's just give it to them. I think you can never assume that they know what they're doing, or that they have your best interest in mind. You really have to protect yourself from that.
That's super helpful, and I think people really want to understand from you your perspective. But for organizations that have outsourced revenue cycle, what changes about leadership's role, your role, or the folks responsible for revenue cycle? Does accountability for you get easier, or is it now becomes harder to enforce?
It's harder to enforce because I can't do anything about the fact that they have a cash poster that's posting things to the wrong place, or writing things off for the wrong reason. I can harp on the management there, but I don't have any way to actually do the training or affect change on what's happening. So I think that while it might seem like it gets easier because your team gets smaller, you really just have less control over how things get addressed when they're not going right.
Sure. No, that's super helpful. And I would say I'm not gonna throw the next one to you because because we've been beating you up about this. But Amy, you see lots of folks that are out there. You work with lots of hospitals. In your opinion, what's the biggest misconception that hospital leaders have about what an outsourced partner is actually responsible for versus what stays on them?
I think the biggest misconception is that the outside partner is going to save the world, and that they don't have to worry about revenue cycle. And I would say that that's on an outsourced partner, as well as maybe a billing, their internal billing resources, that they don't have to worry about it because someone else is taking care of it. We do go to some assessments where the hospital is here, but the revenue cycle is across the street and down three buildings. That when they need to understand that revenue cycle impacts your entire organization. We did have a question that came in that is asking about provider enrollment and verification of hospital enrollment, and I'm like, that is a key question, because yes, revenue cycle starts when that first provider is hired and wants to perform a service, and that organizations need to recognize that everyone has a part in it, and whatever they can do to help support it, it becomes a very um, giving relationship, and having that. And so I would say what we have seen best, and I know the question was addressed to Melissa to say if you've had any problems with provider enrollment verification. Best practices that we see out there in the industry is that at the point at which you are starting to look for a provider, you need to notify your revenue cycle team, because there's paperwork that they need to have that they send off to an insurance company to be done. And if we have anybody in California listening, it's going to take 180 days to get them enrolled with Medi-Cal. And so if you think about the provider started in January, and that you will not receive any reimbursement from your plan for at least 90 to 180 days later, you really have to manage that. So as part of that new hire paperwork, including as part of it all of the credentialing information that you will need for your your for your revenue cycle teams and
Melissa,
staying
do you
on
have
top of
anything
that.
to add to that? Start there. Go.
Yeah. I was going to even here in Maine, I mean, 90 days is really minimum to get hardly any insurances on board with a provider. So we bring in the person that does our enrollment, our provider enrollment super early. Like as soon as there's an offer made, before they even have HR paperwork, they have their paperwork to do the enrollment. So, we loop her in literally before we even loop HR in.
Do you,
That's amazing.
Melissa, do you also manage, like if they're working in the clinic for your hospital, do you manage like which patients the provider can see so that you're not running into that?
So if they're not enrolled with all of the insurance companies, we try to manage what they're seeing for patients until they are enrolled.
Mhm.
And with a lot of things, you can hold the bills until the enrollment is effective
Right.
and then release the bills, which is great. But like you said, then sometimes you're waiting 90 or 120 or 150 days for your money. And if it goes a really long time, I mean, we have providers that we've been back and forth with insurance companies for months and months. So if those providers during those months saw patients that we were holding the charges on, a lot of them have fallen off for timely before they've even been billed.
Yeah.
So that makes it a little bit difficult. We try to be especially careful with our surgeons and the really high dollar claims that we're going to be seeing because that we have had that happen where you expect that it usually takes 3 months with this insurance company, so you roll with it, and then for some reason it takes 8 months this time.
Or they don't backdate it and they only date it from the date it came in, and you're like, you know, but
Yeah.
managing that piece of it is another challenge within the revenue cycle side.
Absolutely. Any parting words, ladies? It seems like we're done with questions that have come through. But is there anything that your expertise just says, "Hey, just everybody go home tomorrow and do this"?
I would say we're here to answer your questions. One of the things from a Stroudwater perspective is that know that you're not alone. The challenges that you are facing, that Melissa was facing in Millinocket, you could be facing in other places throughout the country. And feel free to reach out to either myself or Ryan. And here is our contact information for that. We're happy to chat with you about it. If you see something that comes across, just know you're not alone and we're a resource for you. Melissa, for you?
I think I would echo that. And even if it's not reaching out to Stroudwater, you know, reaching out to your peers, I think that was one of the things I had the hardest time with when I first took the CFO role. Because I felt like if I was reaching out asking questions, it made it clear that I didn't know what I was doing. And I think what I found once I kind of developed a group of peers that were reliable, we all have questions. Nobody can know everything. So just never be afraid to ask questions of your peers or your staff. I'm
Yeah.
blessed to have staff that knows way more than I do. Surround yourself with smart people, and that's the key.
And listen to them, listen to what they have to say.
Yeah.
I mean, absolutely. And thank you, Melissa. Thank you, Amy, for kind of closing up the Stroudwater
Thank you.
conference on such an amazing topic, a topic that impacts every single hospital that exists out there, rural, PPS, it doesn't matter. Revenue cycle is a massively important thing. We continue to worry about, cuts and things like that, but it's important for us to make sure that the work that we're doing gets compensated fairly. And with that, we conclude the 2006 CA Virtual Conference. Thank you all attendees, presenters for spending part of the past 2 weeks with us and for your continued commitment to serving rural communities across the country. Throughout this year's conference, we've explored many of the most pressing issues facing rural healthcare organizations today, including workforce sustainability, strategic transformation, capital planning, partnerships, regulatory risk, operational performance, and financial stability. More importantly, we've had the opportunity to hear practical lessons and real-world strategies directly from leaders like Melissa working in rural healthcare every day. We sincerely appreciate the time, expertise, and perspective shared by all of this year's speakers, panelists, healthcare leaders, and attendees. Your questions are also critically important for us to understand what we need to do in order to make rural healthcare better. As a reminder, when you close out of today's session, you'll receive a brief survey pop-up. We truly appreciate your feedback, and it should take less than a minute to complete. Your input helps us continue shaping future conference programming around the issues most important to rural healthcare organizations like yours. We also encourage you to continue the conversations started throughout this conference. If there are topics discussed over the past 2 weeks that connect to challenges or priorities within your organization, we welcome the opportunity to connect further with you and your leadership team. Thank you again for joining us for Stroudwater Associates' 6th Annual CA Virtual Conference. Enjoy the rest of your day. Cheers.
Thank you.
Thank you.